A 78-year-old retired accountant presents to the GP for a routine follow-up after having a recent X-ray for left-sided hip pain. His only other past medical history is back pain from the age of about 30, for which he was initially seen by a rheumatologist. He had received a course of specialist physiotherapy and has been taking ibuprofen and omeprazole ever since with good effect. The X-ray is reported as showing the left hip appears normal with no evidence of degenerative change and no evidence of fracture. There is marked calcification of the spinal ligaments of the lumbar spine with squaring of the vertebrae. Which of the following other findings is most likely to be associated with these X-ray appearances? So this 78-year-old retired accountant after having recent X-ray for left-sided hip pain. Back pain from the age of 30, seen by rheumatologists. Course of specialist physiotherapy, ibuprofen and omeprazole. Ibuprofen is an NSAID for the pain. Omeprazole is a PPI for the side effect of NSAID is a gastric ulcers. The X-ray is reported as showing left hip appears normal, although the presenting complaint is left-sided hip pain. The left hip appears normal. No evidence of degenerative change, no evidence of fracture. But there is marked calcification of the spinal ligaments. This is not even talking about the hip anymore. This is talking about the spinal ligaments of the lumbar spine with squaring of the vertebrae. What causes all this? Squaring of the vertebrae. Sounds like ankylosing spondylitis. And as well, when he was 30, he went to see a rheumatologist and got physiotherapy. Sounds like ankylosing spondylitis as well. Lower back pain. Which is most likely associated with these X-ray appearances. So, X-ray appearances associated with ankylosing spondylitis. A raised ESR. Yes, it's an inflammatory condition. So ESR should be raised. A raised rheumatoid factor and or presence of anti-citrullinated protein antibodies, anti-CCP. I think rheumatoid factor and anti-CCP test for more or less the same thing. It's just that anti-CCP is more sensitive than rheumatoid factor, and rheumatoid factor is cheaper though. So I do either one. Usually you do rheumatoid factor, still clinically suspect anti-CCP. It's not specific for ankylosing spondylitis. In fact, I think ankylosing spondylitis is seronegative, which I believe means negative for rheumatoid factor and anti-CCP. Chondrocalcinosis on X-ray of the knee is talking about pseudo-gout, I think, which is not what we are suspecting here. Paraprotein on serum protein electrophoresis. I think this is talking about multiple myeloma. Presence of human leukocyte antigen HLA-B27. Yes, HLA-B27 is associated with ankylosing spondylitis. But I don't know if everybody has it. I think about 80%, 90%. So the answer is HLA-B27. So they don't have raised ESR, is it? Syndesmophytes, ossification of outer fibers or annulus fibrosis are a feature of ankylosing spondylitis. Was it mentioned, syndesmophytes? No? No mention of syndesmophytes. This is a man gave us a history of back pain, which had started when he was approximately 30 years old. He saw a rheumatologist and received specialist physiotherapy and is taking only a non-steroidal anti-inflammatory drug, NSAID, and prototype inhibitor. His X-ray findings point towards syndesmal spikes in the lumbar spine and squaring of the vertebra. Spinal ligaments. Which point towards ankylosing spondylitis. Ankylosing spondylitis is a disease most commonly presenting in young Caucasian males. Patients can also develop asymmetrical peripheral arthritis, including in the hip joint, which may explain this man's pain given a normal left hip X-ray. Ankylosing spondylitis is most strongly associated with HLA-B27, which is a major histocompatibility complex. ESR is non-specific marker and will unlikely be most indicative of an underlying disease process. The question asks which one is most likely to be associated. Oh well. Anti-CCP C-citrullinated peptide and rheumatoid factor are most associated with rheumatoid arthritis, given normal X-ray findings, asymmetrical joint involvement, and there is not taking any disease-modifying anti-rheumatic drugs, DMARDs. This is less likely. Chondrocalcinosis is a finding of cartilage calcification on X-ray. This is linked to multiple pathologies such as pseudogout and hyperparathyroidism, but not ankylosing spondylitis. Paraprotein is an abnormal monoclonal immunoglobulin or light chain, most commonly produced by a clonal expansion of plasma cells. It's commonly linked to multiple myeloma and other hematological malignancies. X-ray tend to show punched out lytic lesions in the axial skeleton. What does seronegative mean? Seronegative person may have such low levels of RF or anti-CCP in the body that a blood test does not detect the presence of either. Family of joint disorders that classically include ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, associated arthritis, reactive arthritis, formerly known as Reiter's syndrome, and undifferentiated SPA. What's that? Patients with seronegative spondyloarthropathy often present with inflammatory joint pain characterized by morning stiffness lasting more than 1 hour and improving reactivity. NSAIDs may improve symptoms. This activity illustrates the evaluation and treatment of seronegative spondyloarthropathies and reviews the role of the interprofessional team in managing patients with this condition. Seronegative spondyloarthropathies (SPA) are a family of rheumatologic disorders that classically include these things. Recently, these disorders have been differentiated further into additional categories, including non-radiographic axial seronegative spondyloarthritis, peripheral seronegative spondyloarthropathies, and lastly, juvenile onset seronegative spondyloarthropathies. This family of disorders shares several clinical features and has common genetic associations. There is a classic correlation between the prevalence of seronegative spondyloarthropathies and the prevalence of HLA-B27 gene in a given population. The strongest relationship is in ankylosing spondylitis. In the United States, the prevalence of HLA-B27 is 7% of the general population, but is present in 90% of those diagnosed with ankylosing spondylitis. Psoriatic arthritis is it? No, it's not psoriatic. PSA is psoriatic arthritis, right? Yeah, psoriatic arthritis is associated with multiple HLA molecules, including HLB27, HLA-DR7, HLDQ3. In IBD, inflammatory bowel disease, associated arthritis, Crohn's disease, and ulcerative colitis, the HLA association is weaker compared to other seronegative spondyloarthropathies. Rheumatoid arthritis, REA is rheumatoid arthritis, no, Reiter syndrome. REA is Reiter syndrome. Where were we? Reiter syndrome is thought to be quite rare. The typical organisms causing Reiter syndrome are chlamydia, Campylobacter, Salmonella, Shigella, Clostridium difficile, and Clostridium difficile. The other day there was a question. Somebody presented with diarrhea, so you need to suspect Salmonella. And then they present with the typical symptoms: can't see, can't be, can't climb a tree. So can't climb a tree is arthritis, can't pee is urethritis, can't see is uveitis. Uveitis, is it? Yeah, I think it's uveitis. Let's just double check that. Reactive arthritis, Reiter's disease, reactive arthritis, seronegative HLB27 associated. Conjunctivitis, urethritis, and joint pain. It's not uveitis, it's conjunctivitis. Arthritis, conjunctivitis, urethritis, or cervicitis. Okay, luckily we checked. Oh, iritis as well. Huh? Uvea and iris. What's the difference between uvea and iris? Iris, uvea is this part here, huh? Uvea is a combination of the iris, a whole layer. This whole layer is uvea. So anterior uveitis is the same as iritis, isn't it? Anyway, presents with red eye. You have a 0 to finals video. Let's have a look.
Hi, this is Tom from zerotofinals.com. In this video, I'm going to be going through reactive arthritis, and you can find written notes on this topic at zerotofinals.com/reactive arthritis, or in the rheumatology section of the Zero to Finals medicine book. Let's jump straight in. Reactive arthritis is where synovitis occurs in joints as a reaction to a recent infective trigger. And remember, synovitis is inflammation of the synovium, which is inside the joints and acts like a cushion to keep the joints from wearing out. Reactive arthritis used to be known as Reiter syndrome, so you might still see that appearing in older textbooks, or potentially in your exams. Typically, it causes an acute monoarthritis, and a monoarthritis is a single joint, and it's acute because it comes on fairly quickly. And often this is a single joint in the lower limb, most often the knee, and it presents with a warm, swollen, and painful joint. The obvious differential diagnosis is septic arthritis, which is infection in the joint, but in reactive arthritis, there's no joint infection. The most common infective triggers for reactive arthritis are gastroenteritis or sexually transmitted infections. Chlamydia is the most common sexually transmitted infection that causes reactive arthritis. Gonorrhea commonly causes a gonococcal septic arthritis. So if somebody's got a recent sexually transmitted infection, you need to think about both reactive arthritis but also septic arthritis. As far as pathophysiology is concerned, essentially what is happening is that the immune system is responding to the recent infection, whether that's a gastroenteritis or sexually transmitted infection or an other infection, and the immune system response also causes antibodies or inflammation that affects joints. There's a link with the HLA-B27 gene, and it's considered part of the seronegative spondyloarthopathy groups of conditions that, remember, also consist of psoriatic arthritis and ankylosing spondylitis. There's a few associations to be aware of. Bilateral conjunctivitis, and this is a non-infective conjunctivitis. Also anterior uveitis, and also circinate balanitis. And circinate balanitis is dermatitis of the head of the penis. So a quick Tom tip for you. These features of reactive arthritis, eye problems, balanitis, and arthritis, lead to the typical saying which you'll hear quite a lot, which is can't see, pee, or climb a tree. And that saying is quite a good way and a catchy way for you to remember the features of reactive arthritis. So what's the management of reactive arthritis? Well, anytime a patient is presenting with an acute, warm, swollen, and painful joint, you need to treat them according to the local hot joint policy. And this involves treating as presumed septic arthritis until you've excluded that condition, because that's the most dangerous potential cause for this presentation. And this will involve giving antibiotics until the possibility of septic arthritis is excluded. It's important to aspirate the joint, so take a sample of the fluid from within the joint, and send this sample to the lab for gram staining, culture, and sensitivities to look for bugs that could be causing septic arthritis. The aspirated fluid can also be sent for crystal examination to look for things like gout and pseudogout. Management of reactive arthritis after you've excluded septic arthritis is with non-steroidal anti-inflammatories, steroid injections into the affected joint, and potentially even systemic steroids like oral prednisolone may be required, particularly where multiple joints are affected. Most cases of reactive arthritis resolve within 6 months and they don't reoccur, but if you have recurrent cases, they may require disease-modifying anti-rheumatic drugs or anti-TNF medications. Thanks for watching this video. If you found it helpful, it is a reactive arthritis. Management of reactive arthritis after you've excluded septic arthritis is with non-steroidal anti-inflammatories, steroid injections into the affected joint, and potentially even systemic steroids like oral prednisolone may be required, particularly where multiple joints are affected. Most cases of reactive arthritis resolve within 6 months and they don't reoccur, but if you have recurrent cases, they may require disease-modifying anti-rheumatic drugs or anti-TNF medication.
Okay. Yep. Okay, so here's some investigation and management of ankylosing spondylitis. Ankylosing spondylitis is a HLA-B27 associated spondyloarthropathy, typically presents in males, sex ratio 3:1, aged 20 to 30 years old. Inflammatory markers, ESR, CRP are typically raised, although normal levels do not exclude ankylosing spondylitis. HLA-B27 is of little use in making the diagnosis, as it is positive in 90% of patients with ankylosing spondylitis and about 10% of normal patients. It's an easy number to remember. The more accurate number is 7%. It's written here, 7% of the general population. Plain X-ray of the sacroiliac joints is the most useful investigation in establishing the diagnosis. Okay, plain X-ray sacroiliac joints. Radiographs may be normal early in the disease. Later changes includes sacroiliitis, subchondral erosions, sclerosis. So some erosions or sclerosis of the sacroiliac joint, squaring of the lumbar vertebra, bamboo spine, late and uncommon, syndesmal fibers due to ossification of the outer fibers of annulus fibrosus. Now syndesmal fibers, just gonna search a picture so you can see. So, this is syndesmal fibers. So ossification of the outer layer of your of your disc. What disc is it called? Yeah, it just says disc. So this syndesmal fibers form at the sides there. You have anterior X-ray. Yeah, this one you can see, right? The sides of the vertebrae look like they're all joined together because of syndesmal fibers. Usually there's a space in between. And this one you can see some syndesmal fibers forming already. Where will be? The syndesmal fibers due to ossification of outer fibers of annulus fibrosis, chest X-ray apical fibrosis. ankylosing spondylitis. Okay, if the X-ray is negative for sacroiliac joint involvement in ankylosing spondylitis, but suspicions for AS remains high, the next step in evaluation should be obtaining an MRI. Signs of early inflammation involving sacroiliac joints, bone marrow edema confirm the diagnosis of ankylosing spondylitis and prompt further treatment. Spirometry may show a restrictive defect due to a combination of pulmonary fibrosis, kyphosis, and ankylosis of the costovertebral joints. So here you have a dagger sign. You have a sort of like a bamboo spine as well. You can see that it continuous on the sides. This dagger sign is due to the calcification of the spinal processes, ligaments, I think. This is your syndesmophytes here. You can see the vertebrae looks almost like square. Just syndesmophytes. This is your cervical X-ray. See the whole neck vertebrae like fused into one already. There's no longer any space in between. It's your pelvic X-ray. It's your sacroiliac joints. I'm not very good at looking at this. Can't tell. What are we supposed to see? Fusion of bilateral sacroiliac joints. I guess it looks more opaque than it should here. Where is the separation supposed to be? Not very sure. Is it here? Oh, what is this? A squaring of the vertebrae. Syndesmophytes here. Yeah, this one you can see. Cool. Management. The following is partly based on the 2010 EULAR guidelines. Please see the link for more details. Encourage regular exercise such as swimming. NSAIDs are the first line treatment. Physiotherapy. The disease-modifying drugs which are used to treat rheumatoid arthritis such as sulfasalazine are only really useful if there is peripheral joint involvement. The 2010 EULAR guidelines such as anti-TNF therapy. So biologic should be given to patients with persistently high disease activity despite conventional treatments. Research is ongoing to see whether anti-TNF therapy such as etanercept and adalimumab should be used earlier in the course of the disease. Ongoing research is always good. Oh, this is the video that we just saw. There's the website. EULAR guidelines. Main management, physiotherapy, exercise. So physiotherapy plays a vital role, right? Because you want the joint to be moving all the time to prevent the syndesmophytes from preventing any movement at all. So if you keep moving the joint, there's less chance of syndesmophytes fusing together, I guess. And regular exercise and swimming is the same thing. Yeah. Okay.